Hello, everyone. My name is Kim Hekimian, and I would like to welcome you to today's panel of the ARF Eastern Region of the United States. And we are talking today about COVID-19, navigating the reopening and the new normal. And I have two guests with me, Dr. Tsoline Kojaoghlanian and Dr. Lawrence Najarian. And I will be introducing them as each of us gives our talk. The format today will be, I will start by just setting the stage with a few slides about public health, using a few graphs to set the stage. And then I will introduce Dr. Tsoline Kojaoghlanian, who will give her talk with slides. And then she will pass the baton to Dr. Najarian, who I will introduce, and he will give his talk with slides. We will try to keep the slide portion to about just under a half an hour, maybe 40 minutes, and then we will open up for your Q&A. We are very interested in hearing your questions, and there is a way that you can send those questions to the to us, and the organizers will be sending them to us for the Q&A. So please think of your questions as we move along, and I'm ready to start now. Thank you. So my name is Kim Hekimian, and I am assistant professor in the Institute of Human Nutrition and the Department of Pediatrics at Columbia University. And I'm just going to start with slides to set the stage. And I have a quote that I put up on this title slide saying, "Everything will be okay in the end. If it's not okay, it is not the end." And we are not yet at the end of coronavirus, but we want to set the tone of something positive with this panel to give you the information that you need to make the decisions you need for you and your family. So the outline of today's talk is that I will set the stage. Dr. Tsoline Kojaoghlanian will talk about why is there a new normal and how do we live in this new normal, and take questions and answers at the end of the session. And Dr. Lawrence Najarian will talk about similar themes, in addition to which he will talk about navigating COVID for non-COVID medical visits, and take questions and answers at the end. So where are we globally? I'm going to set the stage with a couple of slides on that, and then talk about where we are today in the United States. And I will speak about the important components very briefly about infection mitigation response. These will be elaborated on by Dr. Tsoline Kojaoghlanian. So we talk about differences in testing, contact tracing, and data surveillance. And then lastly, I have one slide to just open up the discussion that I know there have been issues of trust and miscommunication about the coronavirus and how we're supposed to react to it. So we hope to clarify some of those miscommunications today. So I'm starting with a slide. This is from the beginning of July, so the data has somewhat changed, but you can see that there are, since March until July, the beginning of July, each of these countries has experienced very different curves with different peaks. You'll see a green curve on the left, which represents Spain, had a very high peak and then came down. And then you'll see that Brazil has a constantly increasing rate, and the United States, looked like they had peaked around April and then started coming back up again. I'll show you more with new slides. Some people are familiar with the case of Sweden. This is a slide which shows Sweden's cases versus their neighbors in Denmark, Finland, and Norway. And I'm showing this because some people feel that it may have been unnecessary to have a lockdown. And there is an argument that people make that the economic results are such that they overweigh the lockdown measures. However, in Sweden, where they did not have the type of stay-in-place measures as their neighbors, they are suffering from a greater caseload and therefore, of course, a greater number of deaths as well. Now, with this slide, I simply show you the difference between the United States and our neighbor to the north, Canada, where you can see that the first cases began early in March in both countries. Granted, there was much higher community presence of the infection in the beginning of this pandemic. And yet, though it looked like maybe we were peaking in New York and New Jersey in April, we, in fact, many states have started their acceleration now. And you can see a great differential between what is happening in the United States in terms of the acceleration phase and Canada, that appears at this point to be able to maintain their low infection rate, as we had seen in the previous slide with, for example, Denmark, Finland, and Norway. Now here in the United States, I put two graphs side by side. One on the left is New York, and the other on the right is Florida. And again, you'll see that from March until July, you will see an acceleration in New York that those of you who are in this region are very well familiar with, peaking again about mid-April and then coming down and being sort of stable since the beginning of June. And then on the right, you'll see Florida, which had very low case counts in the beginning and appears to be in an acceleration phase in the month of July. And lastly, this is, I think, my last graph. I want to just share with you some of the reasoning behind flattening the curve. And I'm showing you a slide from the state for the state of New Jersey, from a group at the University of Washington School of Public Health that is monitoring this. And if you can see at this slide, you see a text in the bottom there about ICU beds that are normally available in New Jersey. And then you see the dot, that's that solid line across the, horizontally across, which shows we have, just under 500 ICU beds. And then you see that New Jersey had to increase their capacity fourfold in order to meet the acceleration of the infection. And were it not for the very successful stay-at-home policies of the state, we would have absolutely surpassed our bed capacity in the state. And we would have had to consider things like rationing care, which luckily we did not have to consider because we were just shy of reaching full capacity. It is extremely impressive how hospitals were able to double, triple, and quadruple their bed capacity. And in the right, you can see on this dotted line that there's a shaded area. If we're able to maintain the kinds of practices that we have in the state for low infection rates, it would appear that we will have plenty of ICU beds for the pandemic, but that assumes that we're able to stay vigilant with things like social distancing and mask wearing. So what are the patterns in some of the differences we see in these graphs? Some would say it's leadership, because many of the countries or states that have high infection rates now, they downplayed the virus in the beginning, but not all. There are some states and some countries that took the virus very seriously and took early and aggressive action, and they're still experiencing accelerations today. California might be one of those examples. What about testing? Testing, in fact, is a very key tool to identifying your cases. It's the fundamentals of controlling infectious disease. Some countries had testing available early on, some did not. There are always issues with the cost of testing, which is very expensive, and the capacity of communities to be able to process those tests and having all of the supplies necessary for them. And what about contact tracing? That's another key tool to infection control, being able to identify somebody who's positive and then be able to contact those people that may have been exposed to the positive case. That's a key tool in public health, but it's also costly. Here in the United States, we didn't have many staff who were contact tracers, so we didn't have that kind of capacity. And also, we don't necessarily have the trust of the population to be contacted or to give information to a contact tracer. So that's a key tool that hasn't necessarily been utilized universally throughout the United States or the world. And lastly, human behavior differentials. This is a huge lecture in and of itself. I'm not going to get into that, but there have been quite differences, as you know, in your own communities about how people take social distancing measures, mask wearing measures, and so on. And so human behavior has also contributed to the differences in the various graphs that I showed you. And lastly, this is my last slide. I want to just say that there have been changes in public health messaging, and these changes have created confusion. Should we be wiping down every single surface? Should we be wiping down our mail and our groceries? Well, that advice has changed over time. And what about mask wearing? In the beginning, we were told that only sick people needed to wear masks. Now we're told that everybody should wear masks. Well, both of these represent what's incredible about this novel coronavirus. Novel coronavirus means that it's new. We haven't seen it before, and we're learning day by day. We have an increased knowledge of the virus and therefore an increased knowledge of how to prevent the virus. And so this is my last slide as an introduction and setting the stage for today's discussion. And with that, I would like to now introduce Dr. Tsoline Kojaoghlanian to you. And to do that, I'm going to read her bio to you. Dr. Tsoline Kojaoghlanian obtained her bachelor's degree with honors and her medical degree at the American University of Beirut in Lebanon. She subsequently moved to the US to complete her pediatric residency in upstate in Syracuse, New York. And then she proceeded with a pediatric infectious disease fellowship at the Children's Hospital in Montefiore in the Bronx, New York. It is the only children's hospital in the borough, and she stayed on faculty there for 15 years. She has extensive experience in treating a variety of infections in healthy as well as immunocompromised children. And she's a specialist in pre and post travel counseling. She will address travel a little bit today as well. She holds leadership positions at hospital and development and departmental level committees. And she recently moved from Montefiore to Maimonides Children's Hospital in Brooklyn, New York, the only children's hospital in that borough. And she has been tirelessly working in all aspects of COVID-19 at her hospital. And in her work, including in COVID-19, she has been published in premier medical journals. She recently had a publication in the American Academy of Pediatrics journals in the hospital. And she is a board member of the American Armenian Health Professionals Organization. And for these last 5 months has been a tremendous resource for our community. And I welcome Dr. Tsoline Kojaoghlanian with that.
Thank you very much. Thank you for joining, everyone. We have sacrificed a lot in the past few months to keep our families and communities safe. And this collective effort has made a huge difference, as Kim just showed you. And until we have preventive medications, preventive vaccines, or better medications to treat ourselves once we are sick, we are going to have to continue some measures, which we're going to talk about, to keep ourselves safe. So what is this new normal? Why are we doing it, and how? And as also Kim said, a lot of things are changing very rapidly. So what I'm going to present to you today is evidence-based scientific knowledge to up to date. So up to today, and things might change with time. So why do we care about coronavirus? Well, we care because in the best estimate we have now, the fatality rate with this virus is 0.5%. What does that mean? That means that 1 out of 200 infected people will die. And that makes this virus 5 times more deadly than the influenza virus. And we also know who are the most vulnerable who are going to succumb to this disease. Anyone above 60 years of age, right? So our parents, our grandparents, anyone who's obese, diabetic, and anyone who has heart disease, kidney disease, and cancer. So that is a large part of our population. And unfortunately, the SARS-CoV-2 virus is not showing any signs of going away and is doing its rounds with us humans. And it is spreading easily via droplets. So on the graph on the right side is a graph showing you how this, reminding us how this virus is spread. So this virus is spread from person to person via droplets. Droplets are these little particles suspended in the air full of virus, and they are released when someone sick sneezes or coughs. And by sneezing or coughing, it can land on the mouth or nose or even the eye of the person across from that sick person and make that other person sick. So close contact, therefore, with anyone who is infected with this virus, including hugging or shaking hands, could put us at risk. And I want to mention that we learned very much, something we didn't know in the beginning, is that sick people doesn't necessarily mean those who have symptoms, because we do know now that you can carry this virus and transmit with this virus without showing any symptoms whatsoever. So we have been adherent in our tri-state area on a societal level with implementing various low-tech strategies, right? These are not difficult, and they actually work. So if we keep our guards down, the virus will be right back. That's the why. So what is the how? From what I just told you, because this virus may kill us and the way it's transmitted via droplets, a simple way of thinking about this is avoiding the 3 C's. What are the 3 C's? The 3 C's is the first C is a closed space. So obviously, if there is poor ventilation and the space is closed, then there's going to be virus transmission. The second one is a crowded place when there is many people nearby. And the third C is the close contact setting. So not only crowded, but somebody is close to me. Again, remember, I said someone close to you coughs, sneezes, or sings, or even close range conversation can put us at risk from someone who has the virus transmitting it to us. And the highest risk is if we have all these 3 C's together, as you can see in that graph down on the left down. If all 3 circles overlap, we are in a closed space, a crowded place with close contact, then that's going to put us at highest risk. One thing that's not in the 3C, but it's also important, is prolonged contact. So the longer the time spent in these 3C's, then the higher the risk. In addition to the 3C's, of course, we have to clean high-touch surfaces, wash our hands, we have to stay home if we are sick, and we have to wear a mask, and I'm going to talk about that later. So experts have come together from the Infectious Disease Society of America, the CDC, and have guided us by telling us that, look, guys, it's all about risk reduction. We know what the virus does and how it transmits. So now that we are out and about and are able to do things, what is considered low risk, medium risk, and high risk? And of course, those who are vulnerable should strive at all times to be in low risk. However, if a young person who is not considered vulnerable catches the virus and goes and visits, let's say, their grandparent who is high risk, they can transmit the virus. So we have to make sure that everybody abides by low risk behavior as much as possible. So let's go through some of these, and then of course in the Q&A session we can elaborate a little bit more. So you can go on vacation, but please stay in a rental in a rural area, not a crowded place. You can go to the beach as long as there is few people. You can go for a walk, run, or bike with others or with your family. You can play non-contact sports. You can go to a barbecue as long as it's outdoors, it's in a backyard, and there is ample space for physical distancing. Remember the 3C, and it's not crowded. So if a backyard is small and you put 50 people in there, there's no way you're going to be able to do distancing. So that's going to immediately put your risk up. Getting takeout from a restaurant is fine. Going grocery shopping and going to the doctor's office that Larry is going to talk about are low risk. Medium risk, on the other hand, is air travel, and I'm going to expand on that a little bit. Riding the bus, especially if it's a long ride, staying in a vacation rental in a busy or urban area, swimming at a pool where it is crowded. So if you're in an ocean, obviously you have much more space to keep your distance from others versus if you're in a pool. Playing low contact sports is fine. Going to church, as long as the church is not crowded and there is no singing, is fine. And now once we are at a dinner at someone's indoor house, even if there is distancing and if there is that 10 people, as long as it's indoors, it's going to put us immediately at a medium risk. Eating outdoors, again, as you guys all have seen, restaurants have created outdoor space, and that's fine, but it's not zero risk. It's actually medium risk because, again, you are interacting or sitting nearby other people. Going to hair salons, malls, and libraries is also medium risk. Now, of course, the highest risk is going on a cruise, and right now cruises are not really allowed until the end of September. Going to a crowded beach, going to a gym, eating indoors, going to large concert venues, going to bars, going to movie theaters are all considered high risk. So if I am obligated to be in a medium risk situation, right? I have something to do at the mall, I really have to go. So what else I can do to reduce my risk? Now is where the face coverings come in. So if you are involved in any risk, low, medium, high, please wear your masks. If it's a zero risk, you're at home by yourself or you're driving your car, you don't need to wear a mask. Reminder why we have to wear a mask and why we now have evidence showing that it works is because, as I said earlier, the virus is transmitted via droplets, right? So if I'm telling you, if I speak or cough or sneeze, I emit virus. So therefore, covering my nose and mouth where these viruses come out of is going to help me. And also, guys, the contagiousness of these virus is long. It can last up to 14 days. So I might have the virus and I might be passing it around for many, many days. So that's a second reason. And the third reason is, as we also said, many people don't even know that they have this virus. They have no symptoms. So therefore, the only way they're going to prevent transmitting it to others is by wearing a mask. So please wear it to protect your fellow citizens. Wear it correctly, as I am showing you on a graphic on the right side. I like this cute graphic. And this face doesn't have to be a surgical medical grade mask. It can be cloth as long as it's layered or thick and washable. So there is now data accumulated by modeling and by actual papers showing that mask wearing reduces the risk of catching the virus by up to 70%. So that's an additional thing we can do in addition to reducing our risky behavior. So for example, in New York City right now, we are in phase 4 reopening, which means social gatherings of up to 50 people are allowed. Indoor religious gatherings are allowed as long as it doesn't exceed 33% capacity. So if I'm allowed to engage in medium risk activities, I have to additionally, to reduce my risk, wear the face mask. So let's discuss a little bit travel by air. In my opinion and my recommendation is to avoid non-essential air travel. As Kim said, I live in Beirut. I visit my parents twice a year and I'm not going to be able to go this summer and I have to live with that. So best to travel by car, guys. New Jersey, New York, Connecticut have beautiful areas. Get in a car, RV if you want, and discover your states. If you have to fly, make sure that the flight is short. As I said, as long as the contact with someone else is short, the risk of getting the virus is low. So if you are 6 hours in a plane versus 1 hour in a plane, that's a big difference. Now, the reason why air travel in general is medium risk and not high risk is because airplanes do have strong, high efficiency particulate air filters, HEPA filters that remove 99% of airborne particles, and there is constant circulation of fresh air in the cabin. So that's the good news about planes. And thirdly, know where your airline stands. Different airlines have different recommendations right now. So if I were you, I would double check before you book a flight that the airline is blocking seats, that the airline is requiring passengers to wear masks in the flight. Unfortunately, they cannot mandate it by law because it's not a federal mandate, unlike seat belts, but it's highly, highly recommended. And as I showed you, please comply with it. And they should allow you also to rebook if you are sick. Nobody wants anybody who is sick to get on the plane. And increasingly, more and more countries are requiring a negative test before you enter that country. Speaking of testing, I just want to briefly remind everyone that there's two types of testing. PCR, which is the nasal swab and tells me I have the virus, versus antibody. The indications to do the PCR nasal swab are the following. When you are symptomatic with COVID-19 symptoms, when you are going to undergo a surgery or chemotherapy or you are pregnant, or when you have had close contact with someone you know who has COVID-19. At this point, I would recommend, if all three of the above are happening or any of the three, please go get the PCR test. The reason why I don't recommend anyone to go get the test if they have no symptoms is because of two things. Because one, that tells you only that day that you don't have the virus. It doesn't mean that you don't have it for the rest of the week, for the rest of the month. So it's only good for one day, a negative test. And also right now we are having shortage of tests. It's taking 7 to 10 days to get these results. So by that time, the test is not useful. As far as the antibody test, which is the blood test, we are still doing a lot of research on that. And right now, there's really no reason to go get the antibody testing because it doesn't tell you that you're protected from the virus if it's positive. So you still have to comply with all the measures we are talking about. What do we know about children? And this is a segue to reopening schools. What we have learned and are learning are the following. The incidence of infection is definitely lower in adults. So if we take all the positive PCR nasal swab cases in the United States, 7% only are in children. So it's possible that children have either no symptoms or our symptoms are so mild, and that's why they are not being tested. And we know that to be true. And as Kim said, I published that in recently, because in our experience, kids with COVID-19 have really mild symptoms, just a mild sore throat, low fever. So that's different from the typical COVID-19 that you guys have heard about that occurs in older adolescent adults. So I'm talking about cough, shortness of breath, and pneumonia, right? That doesn't happen much in kids. Severe illness is also far less frequent than in adults. Let's say very, very few, like about 1,000 kids have been in intensive care units in the country versus, of course, 100,000 in adults. And then you have heard about this multisystem inflammatory syndrome in children, which is temporally associated with SARS-CoV-2 virus, and it is occurring in seemingly healthy children, and it's emerging as a serious complication, but luckily a very rare complication. And what we also are trying to find out is, are children contributing to SARS-CoV-2 transmission in the community? So does the virus go from children to adults or the other way around? And to what extent does that happen? This is just a quick reminder of the hospitalization according to age. The red one obviously is 65 and up, and it keeps going up and up in the country, cumulative. And then the last two, the yellow and the black, are the kids. So again, good news that kids are hospitalized at a low rate. And for those of you who are in the 18 to 49 age group, that's the light blue. It's not zero, guys. Okay, so we do know that young adults are also being hospitalized. What is MIS-C for those of you who are parents and want to know what to look out for? As I said, it is rare. Only 1 in 100,000 kids have this, may develop this complication of COVID-19. The average age of kids with MIS-C is 8 years old, and it is a spectrum that varies from mild to severe conditions where different organs of the child can become inflamed. More seriously is the heart inflammation, but the brain, the skin, the intestines, and the kidneys can be inflamed as well. And some of these MIS-C children have signs and symptoms that are similar to another disease that we are familiar with called Kawasaki's disease. This is a disease where the blood vessels get inflamed and enlarged. And on the right side, I'm showing you some of the signs of MIS-C or Kawasaki, where the eyes are bloodshot red. There is a rash, as you can see on the cheek, and the lips can be very red and very cracked and very inflamed. So when to suspect MIS-C is when a child of yours has persistent fever, high fever for 2 to 3 days, and they do have past exposure or past infection with COVID-19, and they present with abdominal pain, vomiting, diarrhea, the rash and the red eyes, as I talked about, and they are extra tired, then please take, and they might be confused, please take them to their pediatrician. To what extent, as I said, are children transmitting SARS-CoV-2? This is central to making informed public health decisions, how we're going to safely open schools, childcare facilities, summer camps. These are important because we do know that if kids do stay home, there is the potential for significant developmental, social, and health costs that children will suffer. So I'm going to present to you the good news and then the bad news. There is some good news. There are small studies, but there are studies showing that, for example, one study from Geneva, Switzerland, looked at 40 kids under 16 years old, and they went and traced to see who in the household is also infected. And they found that children were the suspected index case in only 8% of households, meaning their symptoms started before the symptoms of the adults. So in the other 92%, the adult became sick first, suggesting that the child was not the source of the infection, and they acquired the virus from adults rather than transmitting it to the adults. To the adults. Also, I also said that children are mostly mildly asymptomatic, and because of that, they may have weaker and less frequent cough, releasing fewer infectious particles into the surrounding environment. But there are caveats, and there is the other flip side of the coin. So some of these studies, not the Geneva one, but a few others where they claim there is no child to adult transmission, they were done when in general, in their community, the level of virus transmission was very low. Okay, and that's key, and I'm going to focus on that in the next slide as well. The second thing is, remember guys, the schools closed sometimes even before the stay-at-home measures. So because the school closures occurred along with or before widespread stay-at-home measures, most close contacts became limited to households, meaning the kids were already in the house, and therefore there was no opportunity for them to be infected in the school and in the community and present as index cases. So this is an active area of research. And also another example is Israel, when they plateaued and then they said, okay, we're safe to reopen. They opened normally without any safety guidelines, and they had several outbreaks, including one outbreak of 200 cases in a middle school, high school. So, as I said, when we think about a school opening in the next month or two, we have to do, it cannot be a countrywide formula. Every town, every community, every city, every state has to look at their data and make their decisions accordingly. And the most important data is real-time community-specific virus transmission. So what is the positive rate of infection, percent positive rate? So if I do 100 tests, how many tests are going to be positive? If it's under 5, only 5 out of 100 people are infected, then we can safely open schools. If it's above 5, then that's not going to be good. And then the trends are also important. As you can see, Massachusetts in June has shown sustained decrease in their rates, that's on the left, versus Texas in the last 2 weeks, they have shown sustained increase in their rates. So a trend is also very important. So my last slide is going to be, therefore, the recommendation that parents and schools have to be ready to pause once there is widespread or sustained transmission in their communities. So they can open if there is low transmission, but once we see trends of increasing transmission, we need to be ready to pause. The CDC put out the guidelines on this week about school reopening, and some of them are listed here. Decrease class size, increase desk space, keep the same children in small cohorts, including for recess, eat lunch at the desk, including the teacher should eat lunch there to avoid gathering in conference rooms and eating lunch with other adults. Masks should be worn, especially for older children. There needs to be plenty of automatic sanitizer stations, and there needs to be adequate air circulation, especially in the winter. We cannot be outdoors or open the windows. Another thing that's going to be very important is to keep the child at home when they are ill. And there is a formula that worked in Europe that we might look into as well, is that they put the younger children first. They started younger classes and then the high school. Attendance has been staggered. And then colleges, of course, is a whole other issue, because how to convince these kids, college kids, to reduce their social life activities off campus. And please plan ahead, guys, including taking your kids, yourselves, and your parents to their doctor's visits and vaccinations, including for those above 65 years old, are extremely important. So I will end with this. My colleague, Dr. Demirjan, who's also a pediatric infectious disease specialist, has this very cute thing that's helpful for parents to review with their kids. It's called the My Back to School Bubble. You can look it up on Google. Thank you for your attention, and sorry if I went a little over.
Yeah, don't be sorry. That was a great presentation. Thank you very, very much. So anybody who has any questions for Dr. Kojaoghlanian, please write those questions. And while we have Dr. Najarian, who is going to be our next and last speaker, and then we will move to Q&A, the three of us, okay? So I'm going to just quickly introduce Dr. Najarian to you. Dr. Lawrence Najarian is a second-generation Armenian American. He is the founder and medical director of the Bedminster Eye and Laser Center here in Bedminster, New Jersey. He's a board-certified ophthalmologist and has served his community for the last 30 years. He's a graduate of the Johns Hopkins University and the University of Pennsylvania Medical School, and he completed his residency in ophthalmology at New York Bellevue. He also has specialized training from both London and Emory University, and he is a teaching ophthalmology resident at New York University and New York Eye and Ear Infirmary. But Tsoline and I know Dr. Najarian as the tireless president of the American Armenians Health Professional Organization based in the New York, New Jersey area. And Dr. Najarian has been hosting weekly webinars for our local community for the last 20 weeks, I believe, ever since the beginning of this outbreak. So I want to thank him for being on with us today as well. And I invite him to start his presentation. And as I said, at the end of Dr. Najarian's presentation, the three of us will be on screen to answer any of your questions. Quite a few of them have come in at this point, but we would love for you to add your questions as well. Thank you, Dr. Najarian.
Well, thank you, Dr. Hekimian and Dr. Kojaoghlanian, both of whom are board members of the Armenian American Health Professionals Association, both of whom have day jobs where they thrive in academia and in publishing. But you have to be aware that they are working tirelessly on behalf of the Armenian community, helping in lectures like this for the public, but also educating physicians and advising representatives for the Republic of Armenia. We also want to thank the Armenian Revolutionary Foundation Federation, the ARF, for all of its wonderful efforts to help educate the community. This is our goal, to help you out of the bubble so you can seek a new balance with the facts, with the evidence. You can make decisions that are best for your unique situation. This has been a trying time, challenging time. There's been a drumbeat of bad news. And there's really two responses that you can have, right? One is to make believe there's nothing going on. Well, clearly that is not good. You're going to put yourself and others at risk. The other response seems intuitive, but that would be to lock yourself up in your house and don't go out, stay in place. Well, that has consequences too that are becoming more apparent. When you look at the calls to hotlines and other psychiatric-related illnesses, they are skyrocketing. When you look at addictive behaviors, when you look at child abuse, they are skyrocketing. And the one thing that we have to also account for is that disease does not take a vacation. People still have heart disease, people still have strokes, people get sick. And what we are finding is the cost of staying home is very, very high. So what I hope to achieve today is give you some encouragement about the measures that you can take so you and your family can venture out, particularly for your health care, which is so important. You know, a report came out of the National Cancer Institute a month or two ago that they anticipate 10,000 more deaths over the next decade from breast cancer and colon cancer because of an interruption of care from people previously diagnosed and people not going for screening. Out of the United Kingdom, a study came out and said 10,000 more people will lose serious vision from macular degeneration, again because of an interruption of care, and they did not seek their physicians during the crisis. And in fact, the US data is very consistent with that. Across the country in the months of March and April, physician visits were down over 60%. In the New York area, I can tell you from many of my colleagues, it was over 95%. But again, disease did not take a vacation. What we also know is that parents didn't take their children for normal vaccinations. Vaccinations are very important. Many of us haven't seen a case of measles or mumps, and that's because our children are vaccinated. Vaccination is a very, very important tool in helping prevent disease. And one of the most important things in addressing the issues of COVID-19 are not only the mitigation issues that Dr. Kojaoghlanian and Dr. Hekimian referred to so aptly, but it's also staying healthy. If you're healthy, your resistance to this virus is much stronger. And yet we're coming into the flu season, and the flu season is colliding with the coronavirus. This has the potential to be devastating. We want to be at the best of our health as we can be. So what can we do? We want to get the flu vaccine. We know that only 45% of us will get the flu vaccine. And yet we know also that over 56,000 Americans die each year from the flu, a truly astounding number. And in fact, in some seasons, it's worse. It was almost 80,000 in 2017-18. Millions of people will visit their doctors from the flu. So why not get the flu vaccine? Give yourself every opportunity for good health. You don't want to come into the flu season, catch the flu, and then have your defenses down and expose yourself, your family, loved ones to the coronavirus. So, what do we know about therapeutics? There's been a drumbeat of bad news, and it's very easy to get down. But as a physician, as someone who's talking to healthcare providers and researchers, I can assure you, we know so much more about this disease today than we did a month ago, 3 months ago, 6 months ago. The rate of knowledge acquisition is truly incredible. We can sit here today and tell you that there are treatments that we know evidence-based medicine works and helps keep people out of the hospital and helps people get out of the hospital should they get sick. On the vaccine front, we know there's over 163 vaccines currently in development. It's truly an astounding number. The average vaccine historically took over 10 years to develop with a 6% chance of success. Yet today, we have 5 vaccines already almost in phase 3 trials, which is truly incredible. In fact, this is called Operation Warp Speed, and it is astounding how fast this is going. Now, this gives us hope for cautious optimism, but we have to be realistically that historically, vaccine development is challenging. But we're hoping over the next 6 months, we are going to receive good news about new treatments and new vaccines. Having said that, we all experienced a shutdown, and the shutdown was like somebody turning off the switch. Unfortunately, turning on the switch is not going to be the same. In fact, we're going to be using a dimmer. We're going to make incremental changes as we already have, as demonstrated in the New York City area. And things are slowly getting better. But along the way, we have to hunker down and be prepared to adapt our lives to the new realities so we give ourselves and our loved ones every chance of success. During the plague, Albert Camus wrote in his book called The Plague that the microbe is natural. All the rest, truth, integrity, and purity, is a product of constant vigilance, a vigilance that must never falter. We have to internalize best practices, which include social distancing, good hygiene, good hand washing, and good health practices to give us every chance for our families to stay healthy. One of the things that we can do is just an awareness of how often we touch our face. We've all experienced Zoom calls, too many Zoom calls, and when you watch people, it's amazing how many people, all of us, will touch our eyes, our nose, our mouth. And this is really something we really want to break the habit. In fact, as I'm speaking with you, my hands are in a locked position to be sure I don't touch my face. Now, why is that important? Well, as Dr. Kojaoghlanian mentioned, this disease is spread through respiratory droplets, and smaller particles of these droplets will go on surfaces. And when you touch a computer, telephone, bathroom fixtures, which are high-touch surfaces, you could potentially contaminate your hands and then inoculate yourself when you touch your eyes, face, or mouth. So please use every effort to not touch your eyes, face, or mouth. There's an expression, know before you go. And as we begin to venture out of the home to do our routine activities, we really have to be prepared. We have to have situational awareness. We must be aware of what the disease status in our community is. Clearly, if you're in Miami today, which is a hotbed of activity, you're not going to be going out to a restaurant, outdoor activities, or maybe the beach. If you're in the phase 3-4 area where it's relaxed, you'll be more inclined to go out. But still, you want to be on your guard. You want to avoid crowds. Crowds are bad. You wouldn't drive to New York City or any major metropolis during rush hour because there's a crowd. It will take you hours. You want to go at low volume times to your supermarket. You want to avoid prolonged visits. So, for example, if you have 2 people that can provide the same service for you, one does it in 15 minutes and one does it for an hour, clearly you want to go to the one that does it in 15 minutes. So again, you want to avoid any prolonged exposure to anyone. Assume other people have the infection and you don't want to catch it. You want to do as much as you can do online. For example, banking, ordering payments, and even visiting your doctor. Over the last 4 months, my practice has changed considerably. In fact, every day now, I do something that I never did before, telehealth. It's amazing. As an ophthalmologist, there's some things that I can't do because we do things very close, eye to eye. But there are many things that we can do, particularly reassure patients and help them with their questions. So see if your physicians do this. Call ahead, check their websites, ask how they're proceeding. See if their precautions stack up to the things that we advise most practices do. I can tell you that my family is very concerned about me going to the office and visiting with patients, but I can also assure them that in my office I feel safer than when I go to the supermarket. So we have to rethink the patient experience. What changes can we make in the office to make our staff feel comfortable, make our physicians feel comfortable, and help patients come with their problems so we can help them through it? We have to address the spread through respiratory droplets and small virus particles in the air. And again, we have to use every means possible to avoid face-to-face contact. How do we go about that? Well, we use telehealth. We communicate with patients while they're in their car. We will screen them. Are they having any COVID symptoms? We will also go over some of the routine questions that we normally ask in the office. Instead, we'll ask them while they're in their car, or we'll ask them ahead of time before they come to the office. As they enter the office, every staff member and every patient will receive a health screening. We will ask them a series of questions and take their temperature and record it, and we all have to sign off on it. Personal protective equipment is very, very important. We all wear our masks, and we instruct our patients as they come in to wear their masks properly. It is amazing how many people will wear the mask below their nose. It's also unfortunate to see many masks that have been overused and are soiled, which are totally useless and not protective to the patient and not protective to the staff. At that point, we will ask them to buy a mask at our cost to protect us as well as them and their families. We also wear goggles to protect our eyes, which again is a source of infection. If you touch your eye, where respiratory droplets should go in, and wear coats and other protective gear so we don't spread this outside the office. We make every effort to minimize our contact with the patient. We still want to provide top-notch care, but we won't talk with them as a close distance like we used to. We will talk them from 6 feet away. We will leave the doors open. We want a good flow of air in and out of the office. We also have plexiglass and permanent glass solutions, again, to put protective barriers up to protect our staff as well as our patients. So these are some of the things that we're doing, including frequently cleaning high-touch surfaces, bathroom fixtures, and doorknobs. Hand sanitation is very important. In fact, as you enter the office, when you're having your temperature taken, you'll be asked to wash your hands with hand sanitizer. And we also instruct people again on their proper hygiene. And one thing that we see patients do quite commonly is touch their mouth with their mask to adjust it. And again, please do not touch the front part of your mask. That is the worst place to touch. As far as the things that you don't see, before you get to the office, each room is disinfected and cleaned. This is really a really remarkable thing, how we can disinfect the rooms. We have special hypochlorous acid sprays, which get into the nooks and crannies where a regular wiping system can't. But cleaning and wiping is also effective in cleaning the rooms. The rooms are also aired out. The other thing that we like to do is make sure that the air is turned over. Dr. Kojaoghlanian mentioned what airplanes do when they have special HEPA filters. We've changed the filtration system in our office as well, and we also added a UV cleaner to be sure that we can minimize the amount of live virus that's hanging around in the air. We also, again, try to get room air, external air into the room as much as possible and keep the rooms open. So these are all things that are going on beyond the scenes, but these are things that you should ask about your physicians before you visit. What are they doing to protect you and protect their staff? In terms of evaluating the patient experience, we all have had experience in doctors' offices. Traditionally, we go to the front desk, we sign a register, we touch a pen that other people have touched throughout the day. We touch a pad, we're given paper, we sit down, we touch our chair, we fill out the paper, we then hand in the paper, we go back to our chair, we touch the magazine, and so on and so forth. Multiple opportunities to spread the infection. What we've done is analyzed our patient experience, and what we've done is created 3 stops instead of 7. You're not going to be coming to our office and filling out paperwork. We request that you fill out the paperwork at home. You email the paperwork in or bring it. And then on the exit, you're not going to be doing credit cards or touching credit card machines, other high-touch surfaces. All of this is done before and after the visit remotely. So again, this is something you want to see how your doctor is handling this. But the concept is you don't want to come into a waiting room with 10 people in it. If you see that, you want to leave. So there is a new normal in the post-COVID world. I happen to think it's very positive, reassuring patients and parents that they can bring their children to the office, get their routine care. We've offered mechanisms for patients to receive care when they can't come to the office or they're too afraid. Telehealth is a very viable option. We're spending much less time in the doctor's office than we used to. We're also adopting best personal hygiene, and we use the opportunity of your visit to instruct you on these techniques so you can internalize them. And I think this is what's going to help us as we move forward. You know, hospital-acquired infections is a persistent problem, and as well as office-acquired infections. And I think all of these sanitation and hygiene disinfecting techniques that we're using will really ensure a healthier future for all of us as we move forward, keeping in mind that this pandemic is a marathon, it's not a sprint. It's not going to go away as quickly as it came on. We're going to make incremental changes very slowly, and we see that. They're incremental improvements which, when taken together over a long period of time, are truly incredible. So I think our future is optimistic. We can go out and interact with the world. We should get our routine care. And again, I want to thank everybody for their efforts to assist. This is something that requires each and every one of us to do. It's amazing. You know, we talk about therapeutics, we talk about medicines and vaccines, but it all comes down to the basics: good hand hygiene, masking techniques, and if you're sick, use good judgment, stay home. Thank you very, very much, and we look forward to your questions.
Thank you to both of you very much for such informative, detailed presentations. There's a lot of information in there. Luckily, our viewers can play back the sections of this video that they'd like to review those slides again. And in the meanwhile, we're taking a question and answer. And I would like to start with Dr. Kojaoghlanian with a question that comes from a viewer who has asked, can you comment on any of the serious complications that are possible with COVID even after you recover?
Sure. So referring to adults, we have evidence now that those who are having to be hospitalized, therefore they are sicker to start with, can potentially have a prolonged several weeks of complications. And those complications include excessive fatigue, and weakness. So it's taking them months and months to come back to their normal energy level. And if they did have specific organs involved, so let's say if their kidney was hit with the virus or their heart was hit with the virus, then they are also having complications with that. So we are making sure that we are monitoring very closely people's kidney function and heart function if those were involved for months and months after they recover.
And staying with you, Dr. Kojaoghlanian, the next question is, could you comment on complications of COVID with pregnancy?
Sure. We initially thought that pregnancy was going to be a major risk factor, just like obesity and diabetes. However, United States data is showing that most pregnant women are actually going to do well with this virus, just as if they were not pregnant. So those who are not going to do well are obese pregnant women and diabetic pregnant women. So the same risk factors for non-pregnant applies for pregnant. And as far as whether the baby can get the virus while the baby is in the mother's womb, again, so far there is very scant evidence, one or two little hints here and there that the baby may get infected in the mother's womb, but the majority of babies born to pregnant women have been very healthy. We are advocating for breast milk as well, breastfeeding, because there's no evidence that there is a virus in breast milk. The only time when the baby is going to be vulnerable to get infected is when the baby goes home with the parent. And if that parent is still sick, let's say the mother had COVID-19 right around the time of delivery, then she can pass it along to the baby. So she should be wearing masks. She probably should just pump her milk and let somebody who's healthy feed the baby. There is some data, just like any infection, that there might be a risk of premature delivery in some pregnant women with this virus. But as I said, the majority are doing well.
Thank you very much. Dr. Najarian, we have a few questions for you. If you could, you touched upon this quite a bit in your talk, but if you could talk a little bit more. We have a few questions for you. One is, what questions should we be asking our doctor's office before going to an appointment? And the second is, if I have to go, let's say, to the ophthalmologist's office for a contact lens fitting, what's the advice on navigating that appointment if I feel like I don't know if I can socially distance in the waiting room and things like that? So one is, a specific to your type of office. The other is, in general, what should patients be asking before, as they're making their appointments to go back to dentist's office and other outpatient services?
Yeah, that's a wonderful question. And again, know before you go. Websites contain a lot of information, and a lot of healthcare providers are putting their COVID protocols on the website, so you can actually see what they're doing. What you want to hear is that you're not going to be exposed to patients in a waiting room. In fact, it's no longer a waiting room. It's really a receiving room where we take people's temperature. You want to hear that they are taking precautions with the staff, that there's going to maintain social distancing between you and the healthcare provider, and if they get close, that they will be wearing the proper PPE. So those are the basics. If you can also ask what are the precautions are they taking to clean the room, how they disinfect the room, and what precautions are they taking to air rooms out. These are all very pertinent questions to your exam. As far as the different needs in ophthalmology, initially when this virus came out, there were some questions about whether one should wear contacts, but we now know you can wear contacts safely. In terms of your visit with the ophthalmologist, one has to be very careful, and we do use gloves when fitting contact lenses because the tears can potentially contain the coronavirus, although it's a very low probability event. So the bottom line is we all use lots of precautions and maintain strict social distancing guidelines as much as we can, and the exam is fairly safe.
Thank you. Thank you very much. I think this is for Dr. Kojaoghlanian. The question is, if we do need to fly, should we get tested before and after our flights? And if so, like how soon before, how soon after? If you could speak to that.
Sure. So most countries, for example, the European Union, specifically France, just put out guidelines that anyone entering from another EU country needs to have a negative test within 72 hours of returning to France. So 72 hours is really the cutoff to get the test done. So obviously, for example, if you are traveling to visit an elderly person, so if the purpose of the travel is to go see someone who's above 65, it is not a bad idea to get yourself tested before you go. However, as I said, tests these days, at least this month in July, are taking a while. So plan ahead and make sure that you find a place where you can get your test results within 3 days. Because as I explained, if you do the test today, but your travel is not till 2 weeks from now, a negative test today doesn't mean that you don't have the virus 2 weeks from now, right? So the shortest interval would be 3 days before traveling. And then when you return, as you guys know, for example, New York State right now has limitations on up to 21 states within the United States, where if you do come in from those states that are having high level transmission, you're supposed to be quarantining yourself. For us healthcare workers, because there is a need for us, constant need, we never stopped working, we are supposed to get tested if we return from one of those states, because we cannot afford to be quarantined for 14 days at home. But for somebody who is not in the healthcare business, then, if you are willing to quarantine yourself for 14 days and abide by that after return, that would be the best thing to do, really. And then, of course, if you do develop symptoms, you go get tested. But just to routinely test yourself the day that you return is meaningless, because you may be negative that day, but you can be positive the next day, the third day, the fourth day. And clearly, we cannot get tested every single day.
Thanks. I'm fielding the questions as they come in. Thank you very much for that. I'm wondering if, I don't know if we can leave this screen on for all of us so that we could sort of jump in here. The next question is, and I asked this of Dr. Najarian to start, because when the three of us were talking today, you mentioned that you did do this behavior. And the question is it safe to go get a haircut? I'll start with Dr. Najarian, and if Dr. Kojaoghlanian has something to add, you can add.
I think, again, it's safe, but know before you go. Crowds are not good, and it's not only exposure, but it's exposure time. If someone is going to take an hour to cut your hair, you clearly want, and someone else can do it in 15 minutes and do an equal job, you want to go with the person that does it for 15 minutes. But again, you want to practice social distancing. Be careful as you enter. Where I went, they actually cleaned the doorknobs, and somebody let me in, and I was put in that area at least 6 to 10 feet from everybody else. So I felt fairly safe.
I would add that this is the first time I went to the hairdresser in months and months this week. And safety measures that I was looking for are the following. So number one, I took the first appointment of the day. So if, again, depending on your vulnerability level, so if a 65-year-old is going to the hairdresser or a 70-year-old, make sure they are the first appointment of the day when nobody else has been in there for all night long. And as Dr. Najarian said, if it's crowded, leave. So you can ask in advance, call them and see what measures are they taking to protect you. If they have a waiting room where, like it used to be, many clients sit there, that's not good. And if they say, no, we're taking every half an hour a different customer, then that's fine. And number three is masks. So both you and anyone who's washing your hair, touching your hair, cleaning your hair, doing your hair, have to be wearing masks correctly at all times. So hairdressers are in the medium risk, and therefore all these precautions need to be taken to go.
I also asked the person not to talk when he's putting my hair.
Right.
Oh,
sorry,
no more chatting.
Yeah, I mean, a lot of people like
chatting at the hair salon. Yeah.
And this is also very common in the office. And I think one rule of thumb is when you visit a physician, realize that as much as we all like to chat, we don't want to chat for your health. What the best thing to do is to write your questions down before you visit the physician, so your thoughts are collected and you can clearly and quickly express them so we can address your needs.
Very good advice. Couple of questions on schools. So one participant is saying that our schools have decided to go virtual based on increased number of infections in our area. Based on this increase, should we also be avoiding signing our kids up for fall sports such as soccer and baseball? Local colleges in our area have already canceled their fall sports. What do you think about sports?
Sure. So that's a great question, because it will all depend on when fall arrives, what's your community infection rate, right? So if hopefully from now till September, your infection rates go down, then yes, your child can participate specifically in baseball, because that is a low risk sport with very little contact between the players. Soccer can also probably be considered low risk. So wrestling, where you're touching each other, basketball, where the ball is passing from one person's hand to the other, would be considered higher risk. So I would definitely not rule that out. I would wait and see if the activity starts in September. Please, as I said, look what your community transmission rate is. If it is low, please sign them up with all the different things that we also have to do, right? So you have to probably arrive at a different time from all parents. You don't want to crowd the waiting area. If you go to watch a game, everybody has to be separate. There needs to be a lot of hand washing taught to the kids. However, if the infection rate is high, hopefully they will be able to cancel those activities and only resume if they have to. And I mean, if the infection rate comes down. And then again, another thing is that older children are a little bit higher risk, like in the teenage group, than the younger kids. So depending also on the age of your child, probably the safest is between 6 and 9. If they are teenagers, they need a lot of, education about what to do if they resume any sports activity.
Thank you. I'm going to ask them to leave this on full screen for this. This is a question that we do get a lot, and it stems from some of the changing advice over the last couple of months. And the question is really about how much do I need to worry about my surfaces and cleaning in my house? Should I be cleaning my groceries when I come back in from the supermarket? Packages, at some point people were worried about packages, but it seems like there's been a change in messaging. But could both Dr. Najarian and Dr. Kojaoghlanian describe? Let's start with you, Dr. Najarian. Have you been cleaning your own mail and things like that, or have you changed as well with the changing messaging? And then we'll go to Dr. Kojaoghlanian for that. Let's leave this on full screen for this one.
Yeah, I think good hygiene is always very important. When we go to the post office, when we check the mail, again, we try to limit the surfaces that we touch. The mail, we do open the mail and we do practice good hygiene and wash our hands afterwards, but we don't wash each letter that as it comes in. There's some things like vegetables and fruit products that we definitely want to clean. But you're not necessarily cleaning it for COVID. Foodborne illness is still very common in the United States, and you really want to clean it to avoid more common ailments like E. coli and Listeria and Salmonella. But clearly, our understanding of transmission is indicating that we can be less restricted in touching items that are delivered in the mail or through UPS and Federal Express.
I would add that in the beginning of the pandemic, when we didn't have much information about this novel virus, there were some papers showing in laboratory settings, not in real life settings, that the virus can survive several hours on steel, for example. So that in real life hasn't necessarily translated to be true. However, remember the droplets when they, if somebody is sick and let's say opens a door to a common area, let's say the entrance to the hairdresser door. That's something that is commonly touched very, very frequently, and it is made of steel. So I would say use your elbow, use your shoulder, use something different than your hand to open doors that are very, very frequently touched. Hopefully there is an automatic door, but in the absence of automatic doors, I would go into that. Same for elevators. So definitely not groceries, definitely not mail, but when you're outside thinking of something that 100 people before you have touched that same door to enter, you should use something else. And if you have to use your hand, make sure you have a sanitizer in your bag and immediately clean your hand.
Thank you. And the next question is about swimming. It's summer, and what about going to pools, lakes, and the beach? You touched upon it a little bit. Is it safe for us and for our children to go swimming? Is it safe for our older adults to go swimming?
So one good thing is that we do know that this virus does not survive in chlorinated water or in the ocean. So we do know that you're not going to get it from the water itself if you swallow water or if the water goes into your eyes. However, you could get it, let's say, if you go to a pool where there is no distancing and the chair of a stranger is very close to you, less than 6 feet away. So that's why you have to choose the pool that you are going to. Obviously, if it's a private pool or in somebody's backyard where the invitees are 6 people, 10 people, and there is ample space for everyone to have their seat 6 feet apart from each other, then of course you can do that. Lakes and oceans are much, much easier. They're huge. You can easily swim meters and meters or feet and feet away from somebody else. And you can also put your towel very far from somebody else. So I would advocate more for a beach or a lake setting rather than a pool setting this summer.
Yeah, I would agree with that. It's great advice. The only caution I would give is tourist areas. You want to avoid crowded tourist areas. There are pictures coming from beaches in the Florida area that were just packed like sardines, the New Jersey shore. So if you see that, you want to go to a quieter area. Social distancing on the beach is very important. So again, it's not the water that you have to worry about because, as Dr. Kojaoghlanian mentioned, the water is vast, whether it be a lake or an ocean, and the virus is diluted to really very small portions. And in swimming pools, the chlorine is very effective at killing the virus. So what's more important at the pool and these other areas are the high-touch surfaces. If it's a pool, it could be the diving board, it could be the ladders as you leave the pool, and then the people around you. So again, you want to be on very heightened awareness of your situation and the people around you.
Remember the 3 C's, guys. If it's crowded beach, crowded pool, crowded lake, you're not going to want to be there.
So we have an interesting question from an attendee who is asking, why is it that some family members get infected, but others living with them do not, even if they're sharing rooms or, beds even? What is that? And can you talk a little bit to us, Dr. Kojaoghlanian, about testing reliability? And is it possible to get a false negative or a false positive with these tests? And, if we're going back to work soon, should we be getting tested even if the company is not saying it's mandatory? There are a number of questions coming in about testing. So if you could start with the family members. Yeah.
Sure, I'll start with one. So with every infection, not just with this virus, the result is not dependent on only the virus itself, but also our genetic makeup and our immune response and how we respond to this virus. So even within a family, mother and father may have very different immune systems, and their reaction to their to this virus may determine whether someone is going to get sick or someone is not going to get sick. We do know, though, that within households, there is a high amount of transmission, so about 12 to 15%. That's pretty high, which means that this virus is contagious. And even though the one person may not be as sick as the other person, it's possible that the less sick person has the virus but just doesn't develop symptoms. Remember, we're not testing every single person in the household to know whether they are infected or not. So yes, there is individual variability as to how we manifest disease and whether we end up with very severe disease or mild disease. And the second question, as far as testing, the tests depend on where the test is performed. So, for example, a point of care testing, which means that you go at the bedside or in the doctor's office, you can get a test. Those tests are okay, but they're not perfect. So there is a 30% chance that if you get tested by those point of care tests, rapid tests, that the test will be negative, even though you have the disease. So that's why us doctors, we are not relying only on the test result, but we are also relying on the signs and the symptoms to suspect whether someone has COVID-19 or not. On the other hand, the tests that we have in major metropolitan cities and hospitals, major commercial labs and hospitals, are pretty good. Actually 95% accurate. So in the hospital setting, there is a high chance that the test is going to be accurate. And I'm referring in both of these cases to the nasal swab test, which looks for the viral PCR, meaning is the virus there or not there, detection of the virus. And as for the third question regarding returning to the office, as I said, if you have no symptoms and if you haven't been exposed to anyone with COVID-19 and you get a test today and it's negative, it doesn't mean that tomorrow you're going to remain negative and the day after you're going to remain negative, meaning you have to continue taking all the measures we talked about so that you don't get the virus. So if you are returning to an office and the office does not mandate testing, then you don't really need to go get tested.
Thank you. So we have a question from people who live in New York City. And though you've touched upon this in your talks, they're asking again, in areas where you're walking in a narrow area on a narrow sidewalk and it's crowded, someone's jogging, they're talking on the telephone loudly, and you have a mask, but they don't have a mask. Are you at any risk? That's one of the questions. And the second question is again about these restaurants, that everybody wants to go outside and everybody wants to go back to the restaurants, and they're sitting outside but they don't control where the restaurant seats those other people near them. So you might be sitting at a chair where somebody is less than 6 feet from you with their chair, even if the tables are technically 6 feet apart. So could you speak to that? Are those things that we should be worried about?
Sure. So the first question, as far as someone walking by you, talking loudly without a mask or running by you, I'm in the same situation. I live in New York City, and we have learned how to distance ourselves quickly. It almost has become a reflex, right? So if you see someone approaching you already without a mask, you should cross the street. However, that's really being super cautious, because as we said, that the time you spend in close contact with someone is also crucial in transmission. So obviously, if someone is just passing by you in an open space, that's a very, very, very short contact, right? Like maybe 5 seconds, 10 seconds. So the chances that you are going to catch that virus in that very, very short encounter is probably low. However, as I said, I've been doing it myself. I change course, I cross the street, I go aside, I let the other one pass. We all are doing things but you don't need to be crazy about that, because you're outside and the encounter is very, very short. As far as restaurants, I agree. If you see that there isn't enough space between you and the next table, especially that when the next table is eating or drinking, they're obviously not going to be wearing masks, then go to a different restaurant. Make sure that there is ample space and you feel comfortable, that you're far enough that you don't want to hear the next table's conversation. And to be honest, I know hopefully there's young people on this call. If people who start drinking 1, 2, 3 after the other, they become louder and they might forget themselves. So you want to, again, try to go to places that are not full of people just there to drink and drink and drink to the point of oblivion as to their behavior. Hope that answers the questions. Definitely no indoor dining, but outdoor is fine as long as, and just yesterday, I noticed an outdoor restaurant that actually put a plexiglass between the two tables. And I thought that would be a restaurant I would be super comfortable going to, because there is a physical barrier between the tables.
Yeah, and I think the most important thing that you said in the question, Dr. Hekimian, was if you're wearing a mask, should you be concerned? Clearly, there's a risk if someone else is not wearing a mask, but the mask does offer protection, not only from you giving the infection to others, but it offers some protection to you wearing it should the other person running by have a virus and potentially spread it. So wearing a mask at all times when you're in public is a very, very good idea. There was a question about mask wear also. Masks can be very frustrating for those of us that wear glasses and can fog up. One of the little pearls that we use when we operate is we use surgical tape, which is not as adhesive as regular tape, and we will tape the top of the mask to our cheek area so the air doesn't blow into our face. But a well-fitting mask shouldn't create so many problems. There's also a special wax that you can buy. We use a fog stopper. But when you go to ski stores, they also have special waxes that you can put. They were made for ski goggles, but they work well on glasses as well.
I just wanted to get back, and just because somebody asked a question which I think again sums up what we're trying to say today, is the fact that why some people are manifesting severe disease and while some have no symptoms. And that's the exact reason why we're doing all these large scale societal and individual things, because we don't know if the virus hits us, which person we are going to be, right? If we are obese, diabetic, and heart disease, we know we have a higher risk. But if we're a healthy person, I don't know, between the three of us here on this panel, God forbid we get the virus, which one of us is going to be the one who's going to be hospitalized and have complications? And if we knew, obviously we wouldn't be here. And that's why we're saying we need to continue taking all these precautions, because we don't know whose immune response is going to react badly and end up very sick with it, and who is going to get this virus and not even know that they had them.
So on that note, I'm going to ask you a couple of technical questions to each of you before we get to our final question, which is a discussion for the three of us about the fact is that we've suffered from mental health issues and anxiety and depression and isolation, and so we want to go out, and we need to address that mental health issue by going out And I think that what the two of you are saying is that we can do that safely. Before we wrap up on that theme, I would like to just ask a couple of technical questions. Dr. Najarian, we have a participant who's asking, is this 20-second rule still going for washing hands? And is there a difference between using hand sanitizer and hand washing?
These are wonderful questions. The 20-second rule is still valid. The other way to remember it, if you can't count to 20, is sing happy birthday twice. But hand washing is very, very important. Hand sanitizer is very, very good because, if should you go to a public space and touch that doorknob at the hair salon or the post office, you can immediately come back and wash your hands. So I like hand sanitizer. It's very good. Where hand sanitizer isn't good is if after you go to the restroom, then you want to definitely use soap and water. But hand sanitizer is something that is very critical. I think we should all carry it. I have it in my car. My children have it in the car. We're constantly washing our hands. Good hygiene is of the utmost importance. But, you also tapped on something else. Good mental health depends on good physical health. So getting out is very, very important. Taking walks, exercising, whatever it takes to lift your spirits is very good. Thank you.
Thank you.
Add on that, just wanted to say, to be strictly academic, hand washing with soap has been proven to be a little bit better than sanitizer. I'm trying to be strictly academic here. But of course, if we're outside and we don't have access to soap and water, then sanitizers are our only and very good option. And I'm sure you guys know that the FDA released a list of hand sanitizers that actually contain the wrong ingredient, methanol instead of ethanol. So just make sure that you look at the ingredient and make sure it contains ethanol, which means it's alcohol to use for your hands.
Actually, Tsoline, I'm very glad that you brought that up. I meant to bring that up earlier today, that the FDA has a press release. You can Google FDA sanitizer, and you will see a list of all of the sanitizers that they do not recommend that you use. And in fact, they have recalled them so that you can see if the hand sanitizer you're buying in the store today meets their requirements. If the name is not on the list, then you should be okay. But of course, like Dr. Kojaoghlanian said, look for ethanol and not methanol. There is a question, Dr. Kojaoghlanian, you mentioned in your travel slide that if you take flights, you should try to take shorter ones. But members of our community are thinking eventually about traveling to Armenia or traveling back to see family in other countries where there's longer flights. Is there anything that they can do to protect themselves from those longer flights, or what should they be looking for the place that they are going to?
So same things we talked about, guys. Look at the rates of the country you are going to. So if we are okay here now, and we do know, for example, Armenia is having their numbers where we were in March and April, that's probably not going to be a good place to go to, especially that if you go there, you're probably going to be stuck indoors, right? I mean, if there is a high community transmission rate, we're not going to be able to do any of these activities we are doing here in the tri-state area. So but if you have to go, then the same things, you got to wear a mask, and you got to make sure that you choose an airline that is going to require all passengers to wear a mask. Most airlines are doing very nice cleaning of all surfaces, so that shouldn't be an issue. And that's really it. Nothing different just because it's a longer flight. But again, personally, I cannot go to Beirut now for two reasons. Because when I come back, I need to quarantine. And also, unfortunately, Beirut is seeing an increased number of cases as well. That's all I'm going to say about that.
We have more questions coming.
Oh, I'm sorry. I would also add that on the longer flights, they tend to have stopovers, and that introduces another element of risk. So you want to know where the stopover is. And the other that Dr. Kojaoghlanian brought up is if you're traveling on a vacation, the country you're visiting may have quarantine policies. So if you plan to go for a week and visit and be a tourist and fly back, your plans may be changed by a forced quarantine once you arrive in that country.
And testing, as I said earlier, some countries are required that you show them a negative test before you enter.
So I'm not sure where to go because we have so many questions coming in, and they're a little bit
People
different.
are still on?
I think I think some people are still on. We have a couple of questions. I'm going to group them together for the both of you. One is whether or not you can catch COVID-19 from your pet, and the other is whether or not COVID or coronavirus is less serious in the summer heat, and if it's seasonal. So if you could just address the pet and the seasonality, and then we have one more question about school and school teachers, and then I think we'll wrap it up with comments about mental health, the importance of understanding that.
Sure.
So pets.
The one comment.
Yeah.
One of the comments I could make, we're telling people about social distancing, good hygiene, and getting the flu vaccine, and people may doubt whether it works. What's interesting is Argentina is got different seasonal schedule than we have. Our summer is their winter, so they are in their flu season. And they encourage their population to get the flu vaccine. They have some of the highest numbers for flu vaccine this year, as well as social distancing and good hygiene. And they're actually experiencing a downward trend in the number of flu cases, indicating that these combination of measures really works. In terms of pets, we all love our pets. I wish we had a dog personally, but if anyone wants us to dog sit, we will. Dogs and cats are interesting. They can catch COVID disease and they can spread it to other dogs and cats, particularly cats can catch it. But when you ask a different question, can they transmit it to adults? It's really not well documented, and the transmission rate is very, very low, if at all. On the other hand, if someone is sick, they should be quarantining and refrain from getting too close to their pets, not breathing on them, and not doing all the other things that we love to do with our pet dogs and cats. Overall, I think cats and dogs are a low risk. In terms of seasonality, we initially, when this was breaking out, we thought that perhaps warmer states like Florida, warmer climates would be less prone to this disease. But what we're seeing is the same rate of disease in the warm climates as we have in the cold climates. And part of that is our immune systems, our natural body defenses to this virus are naive to this virus. Our bodies have never seen anything like the SARS-CoV-2 virus, which causes COVID-19 disease. So even though maybe there's some seasonal effect, we're not experiencing it from a practical level because we have no immunity to this virus.
Thank you. Very helpful. So, Dr. Kojaoghlanian, you've spoken a lot about schools. I know the American Academy of Pediatrics has put out a statement on that, and I know that there are guidelines, particularly about whether communities are experiencing low transmission or accelerating transmission. The question from this participant is about the dangers or the risks to the educators, not to the children, right? And the question is, how does an educator make a decision about their own safety in the school?
Mm-hmm. Of course, and this is really part of the whole discussion about opening schools. It's not just for the kids, but also the kids bringing the virus home and the teachers who are teaching these kids who especially are vulnerable, they potentially getting infected. So the measures that need to be placed need to protect the teachers as much as the children. So I would say that number one, the teachers should not aggregate together. I'm sure that educators have their own room where they meet, where they eat lunch. So that's going to be something that's going to be completely eliminated. And one suggestion is that the teacher of that class can stay in the class as much as possible the whole day and eat her lunch at her desk. So minimizing contact with other adults is going to be one key factor. The second one is, again, the risk factor of the educator and what classes he or she responsibility is teaching. If it's someone who is diabetes, poorly controlled diabetic with heart disease, now is the time to fix that, make sure that you work on that, so that by the time school starts, that you are as healthy as you can be. And then what classes are you teaching? So as I said earlier, there's data showing that kids 10 and above tend to get infected more and tend to get transmit more than kids under 10. So if there is the possibility of teaching younger kids versus older kids, that's another thing to look into.
Thank you. I'm going to ask the organizers to just leave this on the full screen. I have a couple of questions that came in for me that I'm going to answer very, very quickly, briefly. One is somebody asked about the per capita differences in cases between New York and Florida, since I had shown a slide comparing New York and Florida. And I was able to quickly check that. It is important to ask that question. And it looks like at this point in time, Florida is experiencing about 2,000 cases per 100,000 population, and New York at its in its average has experienced about 2,500 cases per their 100,000 population. And so while New York has had more cases than Florida per capita, the transmission rate in New York has now come down than in Florida. And somebody asked a question about hospital capacity, and this is where looking at these trends, having good testing capacity, having good contact tracing will give us a sense of whether or not hospitals need to expand their capacity for their beds. And one will be the surveillance that allows the other to meet that need. And that is why you may see, moving forward in the fall, some reopenings and some closings. Here in New Jersey, we had openings of indoor dining and then quickly closing those because the transmission rate for the virus is much higher in indoor settings than it is in outdoor settings. So we, as a society, need to be understanding that utilizing our data and the value of that data will help us make policies so that we can flatten the curve, and therefore anyone who needs a hospital bed, if they do become sick with the virus or if they become sick with anything else that would lead them to go to hospital in the first place, that is what we want to do. So collectively, we all want to act in a way that we can ensure for our societies, for our communities, that there will be a hospital bed for whoever needs that hospitalization in order to get well. So with
I do want to mention,
I think, go ahead.
Can I just mention something? So some people may ask that the worst might be over for us, right? We already went through our huge peak, we came down, so why are we in New York, New Jersey, Connecticut, and DC and Massachusetts, whoever is listening to us, why are we talking about this when for us it's over? And I just want to tell you guys that there is studies showing that even in the states with the high infections, like New York, highest hit, if we do a surveillance and see how many people really got this virus, whether knowingly or unknowingly, in the best case scenario is probably around 25%. So 1 out of 4 of us potentially were infected, knowingly or unknowingly, which means 3 out of 4 of us, right, are still vulnerable to this disease. So that's why we are worried about this second wave in the fall. That's why we are saying we need to open everything safely. We need to get vaccinated, because when the virus comes, hopefully it doesn't if we all do collectively what we are saying. But when it does, the 3 out of 4 of us who didn't get it the first round may get it the second round. So that's really why we want to continue being vigilant.
That's a great segue to the next question, which is about vaccines and whether or not, is it a vaccine that's going to get us out of this? So Dr. Najarian, if you can remember your thought there, and then we'll talk about vaccines, and then yeah, let's start with that.
So yes,
there's more questions coming in.
Yes, I think that the vaccine is going to be really, hopefully, if we get it in early 2021 and still a huge part of the population has not been infected, that's going to be really our solution. The miracle solution would be if the virus itself changes, mutates. These viruses mutate, and if they mutate to a point where they're no longer infecting us, which, as I said, is short of a miracle, which is not going to happen, but that's the only other way where we're going to see this virus go away. So hopefully vaccines will come when they need to, and we all will get vaccinated to battle this disease.
Yeah, the one thing Dr. Kojaoghlanian, I think, was alluding to also is there's a feeling that if many of us have the infection, we'll be immune to the infection because so many of us have had it, the virus has nowhere to live and will be protected. That's called herd immunity. And we know at best case, 25% of New Yorkers have been infected. But to get to herd immunity, you have to have a higher number. We're not sure what that number is, but it might be in the 60 to 70% range. So clearly, many more people would have to become infected, which is contrary to our goal here. In terms of the vaccine, it's going to be a wonderful thing. We're also working on what's called plasma treatments. These are injections of antibodies. And they can come from donors. So if there's anyone out there that has had COVID-19, there is a value to your serum. Please consider donating your serum. There are blood centers, collection centers in all the major cities. There's a major study going on with Johns Hopkins, and the preliminary data is looking promising, and we expect to hear more in late fall. There's also monoclonal antibodies, dual monoclonal antibody treatments, which are under active investigation, and phase 1-2 studies look promising. So it's not just the vaccine. It's a combination of other medical treatments, including antibody treatments, which are looking good. So for many of us, we will not have access to a vaccine in best case scenario, even though Operation Warp Speed is manufacturing the vaccine in large quantities. We're talking about vaccinating over 300 million people in short order. That's going to be a very difficult challenge. So I believe we should take a broader view that we have to internalize good hygiene, mask wearing, other social mitigation measures in combination of taking advantage of the newer therapies. So this is going to be an incremental process, and from day to day it seems to change, but over the long haul, life will get back to what we knew it. It's just going to take time.
With that comment, I'd like to just offer that each panelist will give a wrap-up comment. And I would like to offer to the audience that's listening that as we get more information about vaccines, as we get more information about how long the antibodies last, whether it's in antibodies that we have from having had the virus or antibodies that are produced through a vaccine. As we get more data and research, we're happy to have another forum like this for the community. But at this time, we don't have a lot more information than that which we have offered you here today. So I'm going to ask Dr. Kojaoghlanian to just wrap up with her final comments, and then Dr. Najarian, and then myself. And I want to remind the audience that if you have any further questions, you can contact the organizers of this webinar, and we would be happy, the three of us, to be able to email back to you individually our opinions or thoughts about the information regarding your question. Dr. Kojaoghlanian.
Thank you so much for listening and spending your Sunday evening with us. We hope that you found the information useful. I just want to say that we are in this together. Be assured that the scientific community, the medical community has the best interest of humanity and is working day and night to find solutions to this novel coronavirus. So we, as a society, have to come together and help each other, because this is not like cancer. It doesn't just affect you, the individual or the family, but it's something that is widespread, and therefore if we all come together, it is one way where we can help each other. And if you have any questions, like Kim said, we are always here to help, and we hope you stay healthy, and we'll see you next time.
And I would like to
Dr.
first thank
Najarian.
you. Thank you. I would like to thank the ARF again. This is a wonderful public service. When you have the facts, when you have the information, you can make the best decisions for you and your family. Each of us are going to make unique decisions based on our health history. And I think one of the most important things is to keep optimistic. But if you have feelings of being down, please do not be afraid to call your healthcare provider. Also, please stick with your normal health maintenance. It's very, very important. And if you have any symptoms at all, you're not sure what's going on, do not be fearful about contacting your healthcare provider. It's very, very important to maintain those lines of communication. I talk with many healthcare providers in the course of a day. I know they're there, they care for you, they've set up mechanisms to make your visits, whether it be telehealth or within the office, as safe as possible. You know, this virus has brought us together in ways that we have never thought of. We communicate with people long distances on a regular basis, but we also have learned how important it is to depend on each other. Each of us are so empowered by this virus to do the right thing. If we all, each of us, do the right things with good hygiene and social distancing, we together can make a difference. We've proven that. We've bent the curve. We help preserve hospital capacity for those of us that are unfortunate to get sick, to have that availability of hospitals and physicians to take care of. So we are resilient. We're the Armenians. Being resilient is in our DNA, and that resilience has been called upon. We are in this for a longer haul. We are going to hear about a lot of great treatments and therapies that can effectively help us get better. And it's going to happen, but it's going to happen more slowly than we want. Again, the light is not going to be a switch that's turned on. It's a dimmer that's gradually turned on. But together we can do it. And if there are any questions, please contact us, and we'd be more than happy to answer your questions. So thank you, and we pray for your good health for you and your loved ones.
Thank you for those wrap-up thoughts, and very helpful. Both of you, thank you very, very much. Thank you to the ARF Eastern Region for organizing and hosting. It has been a pleasure to work with you as we organize this. We are going to leave you with a resource slide at the end. The resource is a website for the U.S. Centers for Disease Control. It is their home page for COVID-19, and you can click on that page. Within it, there is a lot of different helpful information that you can get. You can also email ARF Eastern Region with any further questions, and they will send those to us. The email address for the ARF is cc@arfeastusa.org. That's cc@arfeastusa.org. And again, this is the resource slide that you can click on for the CDC. This is the United States Center for Disease Control, and they have a lot of information that you can use to look for the cases in your area. They have data down to the county level, information about masks and wearing masks and how to make a mask, information about disinfectants, about schools, and about travel, among other things. Thank you very much for your time and attention. And we look forward to staying in touch as this situation develops. Thank you both, Dr. Kojaoghlanian and Dr. Najarian, and have a very lovely evening.
Thank you.
Thank you very much.